Hello everyone, I'm Shawn Yazdani here with Dr. Hamid Taheri, and welcome to our first edition of cardiology broadcasting. Hopefully we can do this regularly to help people with different subjects pertinent to cardiovascular medicine. Also I want to say that you can listen to this session as a podcast. If you miss it, it'll be under Heartbeat in all the podcasts. So we're here with Dr. Hamid Taheri, my good partner for over 20 years. And thank you for agreeing to do this. Dr. Taheri is the head of cardiac cath lab at Novant Prince William Hospital and has been instrumental in getting the hospital ready to deal with the pandemic that we're currently in, and of course we're all being affected by it. Welcome. Dr. Taheri, can you tell us a little bit about coronavirus, about COVID-19 virus in general?
So thank you, Shawn, for organizing this, and I hope that this is our first of this type of podcast, so I hope that the technology agrees and you have good quality audio and video for this. So certainly the amount of data coming out on COVID-19 it can be overwhelming, and our attempt was to try to basically summarize the factual data and make this useful for our patients and our colleagues that are dealing with this. And pretty much I think everybody will be affected by this virus in our community one way or another. So it's good to have all the facts and be able to protect yourself and your loved ones. So giving you some basic facts that we know about the coronavirus. So obviously coronavirus is a class of viruses that can cause common cold, and in the recent past, they have also had SARS, which is SARS-CoV-1, had a lot of attention in 2003. So when we are talking about COVID-19, so this is the World Health Organization terminology, and it stands for coronavirus disease that was identified in 2019. That's the purpose of COVID-19. Another name for it is SARS-CoV-2. So it's very related to SARS-CoV-1, and a lot of the treatments are also based on what was done for SARS-CoV-1. They are all in the RNA class of viruses, and we know that this is mainly a bat virus that somehow through an intermediary has made the jump to humans. And once it starts replicating between humans, that's when the epidemic started in Wuhan, China. We also know that this virus binds to angiotensin converting enzyme 2, which is a receptor in body cell surfaces, and through this it can basically gain access to inside the human cells and use the human ribosome to replicate virus structure. And we also know that by the time that the virus enters the cell and uses the reproductive system inside the cell to replicate, it does take almost 5 to 7 days. So this is why there's a latency of effect. So you can have the virus, but you will not have any symptoms for at least 7 days or beyond that. And that's probably why you hear this 14-day quarantine. And so some of the facts that would be helpful to know is some of the environmental sensitivity of this virus. So this is an enveloped virus, which is different than encapsulated virus. As a result of this, which is not encapsulated like a polio virus, this is more sensitive to the environmental factors, which is make this a fragile virus, which is a nice feature of this. So for instance, any alcohol wipes can disturb this envelope. Any chlorinated bleach or detergents can get rid of this virus. It's also sensitive to temperature above 38 degrees. So technically heat can deactivate this virus. And some of the hypothesis is that it doesn't survive in hot temperature, and that's why it starts with the sinuses and the lungs as part of the incubation for this. And also interestingly, it's very sensitive to UV light and sunlight. So technically, if any surface that is contaminated with the virus under direct sunlight, in 3 hours, 90% of the virus is deactivated. So we can use that to our advantage. And there have been some UV light sanitizers that are being used both in the hospitals and for personal items like a cell phone. And now I have seen these UV light that you can put your cell phone or glasses to try to decontaminate. And also, what is important is the surface survival for the virus. It's pretty much anywhere between 6 hours to 24 hours. So we're not talking about days on the surface, but majority of the surfaces, this can survive between 12 to 24 hours. And there has been a New England Journal article that basically did a study, and they found that the plastic virus can last the longest, plastic surfaces. And stainless steel would be slightly shorter, followed by cardboard surface, and copper, interestingly, had the shortest longevity for the virus.
So, by the way, I want to invite anybody who's watching to send us your questions, and we'll be happy to answer. So, just a quick question before we move on. And I was thinking of this today. Let's say you are in contact with somebody who has COVID-19 at an environment like, let's say, this room. Right now, you disinfect and all that. Would you say if you close the door and don't come back to this place in 3 to 4 days, would it be safe to come back, or you still have to disinfect?
No, absolutely. So on the surface, most of the time, depending on the surface, even most of them, 24, maximum 48 hours, it's gone and dried up. So technically, it requires to be going between host to another host, and so technically, if there's an area that has been without any traffic more than 24, maximum 48 hours, you can assume that that's a safe zone. And also, most of the concern has been that since this is an airborne virus, and we are always worried that by just breathing the air, that as we walk through congested areas, we can inhale this, and that's some of the anxiety, because it has been extremely hard to isolate ourselves from airborne pathogens. But interestingly, most of the virus contamination has been through surfaces and touching that surface. So even though you can touch a surface that has been contaminated by the virus, it doesn't get into the skin. So technically, it's our touching our mucosal membrane, mouth, nose, and eyes is how we can bring that inside. So by having a good contact isolation, you can pretty much eliminate a lot of this. Again, this is a airborne and a droplet isolation too. So if somebody directly sneezes, then technically, yes, you can inhale that. And some of the procedures in the hospital that involves direct, like transesophageal echocardiogram, some of the oral procedures, and some of the people who actually have anesthesia procedures that are directly close to the airways, those are considered high risk, and you can have airborne inhalation of this. But for majority of the public, if we can make sure that we have good hand hygiene and don't touch areas, or if you touch them, don't touch your face, and disinfect your hands, it would be, you can protect yourself. And interestingly, some of the healthcare infection, when you look at the data, these are all based on the areas that became hotspot, and the doctors were basically not prepared for this. So by the time they find out that some of the patients have already been in their offices, in the hospitals, and they got infected before knowing this. So especially in China, when you look at the data, there was a large number of healthcare providers that got the disease, but when they send other doctors to that area prepared, none of them were infected. So it's not just being in the hospital, but if you protect yourself, if you have the right gears and take the extra precautions, you can protect yourself as healthcare providers.
Thank you. So let's say you unfortunately get the disease. What is the course of the disease? Can you tell us a little bit about what happens on the day that you actually get the virus?
Yes, so the clinical course has been that for 80% of the patients affected, they have a mild symptoms. And those are usually, it starts with fever, fatigue, and dry cough. That's pretty much universal initial signs of this. And if you start day one from the symptoms, majority of them is the fever and the cough, dry cough. But some of the other symptoms that are pretty much universal among other viral infections include myalgias, body ache, sore throat, and less frequently diarrhea, but that's also one of the reported. But again, the one that is most concerning is the shortness of breath, because that has different meanings. And about 20% of patients may proceed to have more critical signs and symptoms. So talking about the dyspnea, or the shortness of breath, so that doesn't start right off the bat. So usually it's the fever, but by the time the dyspnea happens, it's usually between days 6 and 7. And majority of patients can have uncomplicated shortness of breath, don't require any specific treatment, self-isolation and waiting is enough. But you have to, looking at the data, especially the one from Wuhan, 50% of the patients developed some kind of respiratory failure that required some kind of intervention. Fortunately, majority of them was supplemental oxygen. 50% basically having a nasal cannula, oxygen was enough to relieve their dyspnea. But 20% required high flow oxygen. And about 14% required non-invasive mechanical ventilation, some kind of going beyond the high flow oxygen. But invasive mechanical ventilation, or basically using ventilators, was reported for 17% of these folks. And that's why there is such a discussion and hype about shortage that we can anticipate for the mechanical ventilators. And when patients go on the ventilators, they can stay on that for 7 to 14 days. That's why there is going to be a big demand for ventilators. But once you get through that period, if you are able to support these patients, majority will recover. But if you wait too long, and by the time they go through ARDS that we will talk in a little bit, then the chances of survival is diminished.
And correct me if I'm wrong, but there are a certain percentage of patients that they get such bad lung disease, such as ARDS, that you said that even being on the ventilator will not help them oxygenate. And I believe those are the patients that get ECMO. If you don't mind if you talk about ECMO a little bit and what it is. And I know that is a major concern for the hospitals, especially the tertiary care centers, because that's even of a scarce resources than ventilators.
So talking about ARDS. So ARDS is acute respiratory distress syndrome, and that's when patient has overwhelming hypoxia, and the inflammation and the cytokines in the lungs cause a profound overwhelming response of the body toward the infection, and that can pretty much minimize the oxygenation for the patient. And those patients, whether this happens because of the virus or other causes of ARDS, they require mechanical ventilation sometimes for a prolonged period of time. And patients who have coronavirus, their lungs are not stiff like most chronic lung disease patients. So mechanical ventilation actually helps that. And it's some data suggesting that some tricks of making prone ventilation, patients are basically being on their stomach as opposed to on their back when they're being ventilated, has shown some. But what can we do if the mechanical ventilation is not enough? Then instead of just delivering the air through the ventilator, you're actually delivering oxygen through the body through another device called ECMO, which is the extracorporeal membrane that is basically oxygenating and then sending the blood back to the heart. But it has shown that by the time you go to ECMO, majority of these patients were too sick and they didn't survive. So it kind of brings the question of, even though we are used to using ECMO for our cardiac patients and some of the very sick patients with very good results, the result for patients with coronavirus, whether it was used at the right setting, but looking at the data from China, technically none of those patients made it.
Wow.
Now we are waiting to see our own data from New York and the US trial, US patients' experience to see. But some of the also argument is that if you wait too long to the patients to get to that point, then the utility is not as much. So that's why once the oxygen level goes down, it's recommended to go aggressive and try to oxygenate. So talking about some of the complications that you mentioned, I kind of summarized it in this slide for you. So 60% of the patients can develop sepsis, which is infection associated with this, and that has been reported to occur in day 10. ARDS was reported in 30% of these folks, and that usually in around day 12. And some of the cardiac injury that we'll talk about, those are later on in the course of the disease in day 15. And 23% of the patients develop heart failure, and that's why it's become critical for cardiologists to be aware and familiar with this.
So, I have a question from people who are watching. Does it always, is fever always a presenting symptom, or fever can be a presenting symptom down the road? In other words, do the people present with fever immediately, or that can develop down the road?
So, majority of patients have fever as their initial sign, okay? But what is interesting is that the fever, and I've talked to patients who are infected with coronavirus, and the fever is not necessarily every day. So they would have days that the fever is down, they feel better, and they have this false sense of security that maybe they got through this, and then 2 days later they come shortness of breath, fever. But fever usually is one of the first signs, and that's why they're using that as a screening tool for traveling, and that when it started, and even some offices, we are using that as a way of screening asymptomatic patients. They may not even know they have fever, and the temperature can be elevated. But lastly on this slide, mortality has been reported between 2 to 4%, and on the average for patients who were hospitalized from the onset of symptoms, that was in day 19 to 20. So while we are on this topic, even though it's hard to talk about mortality, but obviously this is what we're trying to avoid. If we can survive this, you will be fine, but we're trying to avoid the high mortality. And there's always this confusion. What is the mortality? You're looking at Chinese data, you're looking at Italian data, now we have our US data. So I actually looked it up today before coming here today, and I added the latest numbers. Globally, the mortality rate of total number of mortality and the diagnosis was 5%. In our US, up till this afternoon, April 1st, that US mortality is 2%, slightly less than 2%. But if you think about this, that we don't have the full number of patients, so there's a lot of undiagnosed coronavirus. So that makes our mortality actually less than 2%.
And I think it's important for people to understand that this is based on people who have been tested.
Right,
and
confirmed
are
cases.
Confirmed tested. There are a lot of people who probably walking around and have been exposed and got infected but didn't realize it. So these numbers are most likely, nobody knows how low it is, but it's certainly lower than
yes,
this.
so that's very encouraging to know that the US mortality rate should be less than 2%, but the confirmed cases right now is 1.9%. And what is interesting also is that looking at the New York mortality, since they have the most number, so I was trying to see if there's any trends to explain when you are overwhelming a system. So far, New York mortality was similar to the rest of the country. So that means we haven't overwhelmed our system, even though we are seeing a lot of the reports that there's a lot of concerns. So far we have been able to manage this, and we're hoping to be able to do this and keep up with the demand for the equipment that we need to take care of these folks. So then if you ask what are the predictors that can predict somebody having higher mortality when they're infected, obviously one universal factor is older age, and there is no limit to say is it older than 70. Pretty much the older you are, the higher the risk of complications and mortality for this. Now some of the markers that can be validate this, or a marker to increase mortality, D-dimer, which is a blood test that we do for a lot of folks that come to the emergency room with shortness of breath. So interestingly, when the D-dimer is elevated, that's an increased predictor for complications and mortality. There is a scoring system called SOFA score, Sequential Organ Failure Assessment, and the higher that number is, also the higher. So that ranges between 1 to 6, and anything more than 2 considered increased risk score. Lactate dehydrogenase, which is another blood test we do when there is signs of shock in the system. It's a predictor. Interleukin 6, these are some of the markers for inflammation in the body that has also been correlated to this. And for us as cardiologists, we are used to checking troponin level, which is a sign of myocardial or heart injury. And interestingly, I have a graph to show you after this that shows the higher that number goes, the higher the risk of mortality.
Wonderful. I have a couple of questions on the cardiac presentations, which I know you're going to go into next, so I'm going to hold those questions for that section. So let's talk about cardiac manifestations of coronavirus.
So cardiac manifestations have been reported in 20% of corona patients, which is a high number considering that. So it's not just a respiratory pulmonary failure. You're now talking about 20% of these folks have shown some kind of cardiac injury, and they have shown to have elevated troponin levels. So some of them, we know that troponin assay can be very sensitive, and anytime there is myocardial injury or cell death in the heart, this level goes up in the blood. And patients who present with chest pain, you always check that to know who is considered high risk of cardiac events. So technically, it can go up for corona patients. And there is a linear correlation with this too. So patients have developed heart failure, meaning that their muscle of the heart can be affected, and they can have decreased muscle function, and as a result of that present with congestive heart failure. Now, more concerning is that patients now have been presenting with myocardial infarction or frank heart attack. Now, interestingly, their clinical presentation is just like a heart attack, but when you take them to the cath lab and look at their coronary anatomy, there is no major lesions to explain this. So even though their EKG, presentation, chest pain, and even the myocardial function looks like a heart attack patient's, but it's not due to a typical blood clot that happens in the heart or coronary plaque. So that presents its own challenges to the healthcare system. How do we know this is a heart attack patient? We have to go very quickly to address them versus somebody that we have to watch and rule out. So that's a hot topic.
I believe you had a patient similar to that a few days ago, right?
Yeah, so, this is a patient who presented to our institution with all signs of a heart attack, but when we pretty much brought the patient to the cath lab and our screening test questionnaire to him, he passed everything, and he didn't have any coronary blockages to explain his presentation, and fortunately he did very well, and he was discharged home yesterday. But when we went back to look at the questionnaire, he basically admitted that, I was actually in New York area for work 4 days of last week. But the initial questionnaire we were asking is, have you traveled outside the US? And he was technically correct. So be careful when you do your screening. You should pretty much, it doesn't have to be outside the US anymore.
And along the same line, and this is a question from the audience, do you have to have underlying heart disease to get a heart injury from COVID-19?
That's a good question. So if you have underlying heart disease, the risk of cardiac complications are more, and that makes sense. But not necessarily. There are patients who have completely normal cardiac function and no prior cardiac history, and now presenting with myocarditis, which is an inflammation of the heart. And some of the hypotheses that are being looked at is that obviously we know that the virus receptor is ACE2, and those receptors are on the myocytes too. So there is technically receptor for this virus inside the heart muscle. So if it gets through the bloodstream, it can attack the heart, and that's potential mechanism of injury for this. But no, the answer to that question is you don't have to have underlying heart disease. But certainly, cardiac patients are at increased risk of complications when you get into this kind of infection. In fact, everybody I saw today through our virtual office visit, I emphasized to them that you are considered high risk, take every precaution, keep your isolation, because I can't imagine when this virus affects some of the cardiac patients who already have compromised cardiovascular disease, it would really be difficult to treat. So a couple of the slides I wanted to show you on the topic of the cardiac complications. So this is a graph that was presented from Wuhan study at Lancet journal. It's showing you, the top shows the survivors in the hospitals in Wuhan versus the non-survivors, to see if there's any difference in their presentation or the symptoms. So the red line, the bar is basically showing from day 1 through day 20. The initial symptoms are cough and fever. And pretty much you can see it looks the same. And obviously the cough and fever start first, but the shortness of breath for both of these groups started around day 6 or 7. And the last bar, this blue line here, is how long they tested positive. So pretty much from beginning to their to the discharge or mortality, they basically were having the virus detected in their bloodstream. Now, patients obviously who went home and they basically stopped showing the virus, but the ones that died basically through the hospitalization, they had the virus. And then mechanical ventilation. If you check on this graph, the red bar, ICU admission is the green bar that happens in day 11 or 12. And then mechanical ventilation was presented later with the red bar here. So these are patients in their Wuhan experience. By the time they did this, it was pretty much so far in advance that none of those patients made it. So you don't see that on the survives. So their experience with ventilation wasn't very good. But because of that, we are actually changing the protocols to offer that much sooner. And the other thing that everybody is talking about is that you can have a very stable shortness of breath, but when they become hypoxic, there is a very fast turnaround that they go through this spiral. So if you feel that the oxygen level is low, and there are actually suggestions that patients who are having this should have some kind of pulse oximeter, you can actually isolate yourself and stay at home as long as your pulse oximeter shows good oxygen level. But when you see that number start to decline, that's your signal that now I have to go to the hospital to get oxygen and further treatment. So just quickly, some of the graph that shows these biomarkers that we talked about. So the red line is showing you for patients who didn't survive. So the first one on the left side of the screen is the D-dimer. You can see the D-dimer continues to rise for these patients, whereas the survivor had a very flat and stable D-dimer. This is the lymphocyte or white blood cell count. That's basically the red shows they had a low lymphocyte count for those patients who didn't survive, whereas the survivors had a good lymphocytic count and response. When you're looking at the interleukin-6, same trend, that the patients who have increased signs of inflammation by measurement of interleukin-6, and the survivors had a pretty much flat response. And serum ferritin is there. But for us, very important, these are very important slides to see. Cardiac troponin. You can see that the survivors had a pretty much normal troponin, but by the time that the troponin was elevated and shows sign of cardiac injury, and especially if there is a trend for higher troponin, these are patients who had higher mortality. And lactate dehydrogenase, which is a sign for a shock in the body, it continues to rise, whereas for the survivor, that number, even though it may be a little bit high, it had a better trend. And while we are on the topic of cardiac complications, looking at what are the predictors of cardiac complications, number one, again, older age and pre-existing cardiovascular disease. For patients who have had prior myocardial infarctions or prior LV dysfunction, those are at higher risk for cardiac complications. And again, also severity of their pneumonia. If they had bilateral severe pneumonia, obviously they were at more risk of developing cardiac complications for some of the hypoxia that can cause this spiral. The D-dimer that we mentioned and lactate elevation were part of those two.
So when you show the troponin level and toward the end of the course on the non-survivors, the troponin level, had an exponential increase, would you say that that's a sign that the patient is getting multi-organ failure, or is it actually a marker of, or do we know?
Yes, that's a very good question. So it's hard to say if that's causing or as a result of and certainly patients who get to the point of multi-organ failure, they are at a very high risk of mortality. And so our goal is to try to prevent the overwhelming body response to get to that point. And for a lot of folks, if we start our treatment early on, hopefully we can prevent that. But by the time you get this multi-organ failure, similar to cardiogenic shock, it's almost like when you wait too long and you get through that spiral, it's hard to reverse that. And certainly the higher the troponin level, the higher the risk of multi-organ failure and cardiac failure. But the challenge is this: how do you treat these patients? Because for us, anytime we saw these high troponins, traditionally we basically associated that with the myocardial ischemia, and we had to go and try to fix the blood supply. But these folks, that's not the reason. So the answer is not to take them to the cath lab. This is a kind of a marker that we have to support them, but there is not a lot we can offer them. So then the question is, if their heart function is low, can we offer them some of the mechanical support? But so far, there has not been any data suggesting that that would reverse this. So certainly in special cases or specific cases, when that's the predominant cause of failure, we can try this, but not when there is multi-organ failure, just going after the cardiac side of this.
So is there any treatment for the virus in general and for the cardiovascular manifestation of it in particular?
So obviously some of the concern we have had is the fact that there is no approved treatment. So pretty much everything we are talking about, there is a lot of active research going on, and I'll mention some of them to you. But pretty much there is a lot of anecdotal data, there's a lot of experimental trials, but nothing has shown to be able to treat this virus. So certainly there is vaccines that are pretty much the longest to be able to offer that to prevent infection. But in terms of antivirals, so for instance, the one that I'll mention to you, but there's actually 7 viruses and trials, 7 vaccines in trials right now, and 16 antibodies and biologics that are being treated. So the reason that the antivirals are the closest to be able to get to the market for us is that because these are the same vaccines that were used for other viruses. So for instance, the one that is closest antiviral is remdesivir, which is a Gilead company's antiviral. The way this antiviral work is basically that interferes with the production of the viral particles in your body cells. So it basically replaces adenosine by a different subject that pretty much does not allow that replication of the RNA, and we pretty much stop the replication of that. Now this vaccine, the reason it's available and it's being tested so quickly is that this is what they tried for SARS-1 and Ebola. So that's why when this came, and there were actually a patient in Washington State that pretty much got compassionate use or experimental use quickly, and he survived. And so there is actually a trial that is pretty much near completion, and we are expecting data in April from Gilead in certain and actually at Innova, we're going to be part of some of these trials for antiviral in Northern Virginia.
So was there success with SARS-1?
Not really, but the problem is that SARS-1 was basically becoming so small, and so there was not a lot. By the time they had this, there was not the outbreak was gone. Yes, but since there is a lot of similarities between the polymerase that uses the SARS-1 and SARS-2 in the body to replicate, that's why these were ready to go, and was nice for Gilead to be able to offer this quickly. Then there's these biologics that are basically anti-interleukin 6 and interleukin 1, that are being tested, but those may take a little bit longer than the antivirals. Then you have the famous Hydraxor, chloroquine, azithromycin that has been all over the news, White House, Dr. Fauci talking about this. So still there is no proven record for this, but there's some anecdotal data that some patients felt, and this is anti-malaria, and I have another slide on this. Anti-malaria that has been basically used for treatment of this, and certainly there has been, as soon as this announcement came, and FDA actually gave the extended use indication for this. So technically, as a physician, you can write this. When I talk to my infectious disease colleagues, and who do you recommend this to? Anybody who has a virus, because it was getting so crazy that people were prophylactically taking this, and there was a shortage of this even for patients who were using this for arthritis. So I had patients there, I can't even get it for my arthritis anymore. But interestingly, no, their recommendation is don't use it for prophylaxis, number one. And even the simple cases that are basically recovering at home, they don't need this. But the infectious disease colleagues are now recommending this for patients who are in the hospital and they are.
So are the patients who are in the hospital with a proven diagnosis going automatically on this?
Not automatically, but I think we are basically relying on infectious disease doctors to make that call for us. But when I called them last time about a patient who's recovering at home, they said we are not recommending it for that.
Is that solely based on anecdotal?
Well, there are actually, there hasn't been any published data, but there has been, I think they're gathering the data right now, but FDA certainly gave that usage to this, so I'm assuming that there should be more data other than just anecdotal. But they didn't want to not have this option in case this turned out to be the, but certainly there are so many patients now that it should be easy to do these trials and have the answers fairly quickly. Mm-hmm. But having talked to some folks that they've used this, they said they felt better. So that's why I think there has been some enthusiasm that this would be an easy treatment. It's available.
I know the president feels good about it.
Right. And then finally, steroids, because steroids have been used for ARDS, and initial data showed that this actually may make the situation worse. So that actually is not recommended right now for SARS patients. Now, once we were on the topic of hydroxychloroquine, when you look up this drug, because we were not familiar with this, at least as cardiologists, other than prolonging QT and some pro-arrhythmic effects, there is a large number of side effects for this. So technically, some of those side effects are headache, myalgias, and so that can actually make some of those worse. But I certainly would not recommend this unless it's a patient that is being recommended this by a professional. But if you are using this drug, just be aware that for cardiac patients, you need to have an EKG, because somebody who, this can prolong QT interval, and that can cause certain arrhythmias.
And especially if they're on their medication.
Exactly, so the drug-drug interactions should be considered.
Well, wonderful. So, and I know this is dear to your heart because you had to make changes at the cath lab where you're directing patient care. What should people do in general, and especially the healthcare providers, to first protect themselves, or as well as not become a vector to transmit this virus?
Okay, so I think I just had a comment that the camera may be vertical. Sorry. Okay, so let's talk about the prevention. So obviously, this is a very important topic because this is how we can basically prevent further spread of the virus. And I think for a lot of you out there that don't have the virus, obviously majority of us, we want to do everything possible to not get the virus and prevent this. And I would recommend, and I think there's a lot of hype about this, I shouldn't call it a hype, but there's a lot of talk about this. I would refer you to CDC. I checked it out last night actually. It has a very nice website and recommendations. So they basically divided into preventive advice, so how to prevent getting the virus, and how do you take care of prevention to your family members if you are a suspected case, or if you are a confirmed case, a different category. And then we have a healthcare workers, how to prevent them from getting this. As I mentioned earlier, the majority of the time is that, and every day the recommendation about the mask changes. I was driving tonight and I just heard that, you know, the recommendation is changing again. But I would say if you have access to it, use it. I was at the grocery store last weekend, and literally when I walked there, I was the only one with a mask, and you know, it feels awkward when you're the outlier. But when I saw somebody behind me had a big sneeze, then I felt good that, you know, I had the mask. But if you have it, use it. If you don't have it, but be aware that this is not necessarily to prevent inhalation of this, because most masks don't prevent that, even our surgical mask. This is for you to prevent the droplets from a sick patient to get to outside the environment. So certainly if somebody is sick, they should be wearing a mask. But for healthcare workers, you hear about this N95.
That subject, it seems to me the social distancing is a lot more effective if you keep your distance. At least 6 feet is what they say. You should not have that droplet transmit to air.
Right, except if somebody sneezes, that 6 feet is not enough. That's why they're talking about, you know, make sure you protect your mouth when you sneeze or cough. And I was watching this this video that shows these droplets, and when you cough, it's even worse than a sneeze, and that can actually go for long. But that's why hygiene measures go a long way. But majority of patients who actually get the virus is through the touching surfaces, because these air droplets or the virus basically settles on the surfaces, and that's when you using your you know, your hand and touch something and then bring that to your face. That's how you get it. So a lot of time this protection is being argued to use that way you don't accidentally touch your face. And it was an interesting study looked at how many times in a day has an individual touched their face, especially for those of us who use the glasses, that that's even more.
And correct me if I'm wrong, but also we use the dominant hand most often. So I think something that's easy to do and you can prevent some of these transmitters, touch the objects consciously with your left hand, because you usually take your right hand to your face, not the left hand, but if you're right dominant.
I'm going to try that next time. So, and certainly my cell phone, and I would highly encourage you, if you don't have these earbuds or earphones, you should get one, because technically if you have them, you don't have to bring your phone to your face every time. And a lot of times now that we are doing this video conferencing in the office, it's so much easier to have that in your ear. So some of the personal protection equipment, or I should say potential protective equipment, PPEs, which has been a hot topic right now, there is shortage of this. And the reason for this is that this is the famous N95. So this is what we used when we went to a respiratory isolation room in the hospital, and this is protecting for patients who may have a TB or respiratory illness, which is, we didn't use this a lot. But what is interesting is there is a shortage of this, and I see some people just walking around trying to find this, but this should be fitted to your face, and this is like a cup, so you have to have the right size. And if we, as healthcare providers, we used to get a test for this, and if you fail the test, you don't need this, you have to go to the next step. But most of the time you are not even getting tested for this. But this is the N95 mask that can protect you from any kind of respiratory pathogen. And make sure if you have this, you pinch the metal on top of the nose. I've seen some people use the mask and there's still air going through the side of the nose. So anytime you use a mask, whether it's this one or surgical mask, make sure you pinch the metal around the nose. But for a lot of healthcare workers, if you have one of these, and you have a face shield, so this is a healthcare worker that is going to be in direct contact with the patient with coronavirus to protect themselves. But certainly for somebody who doesn't have the active involvement, surgical mask would suffice in the hospital. That's why most active staff are walking around with the surgical mask. But these are reserved for people who are treating COVID positive patients. Now, who are the highest risk of getting this? So certainly the anesthesiologists who are intubating, the intensivists who are seeing these patients in their ward, and let's say when we are dealing with the patient in the cath lab, where patients present with a heart attack, and certainly we are trying to look at different protocols, but majority of the time you still have to go intervene without having the knowledge of this patient may end up having COVID. So we should treat everybody as if they have COVID-1 when they're coming through an emergency procedure. So for that, this is a picture of what we call a PAPR mask, a positive airflow protection mask. So the way this mask is, and so we're still wearing the surgical mask under it, but this is a shield and a hood, and there is a basically positive airflow that comes from the back of this mask and basically blowing air through a filter. So you feel that the air is coming through a filter, and what you're inhaling is not coming from the patient. So you are basically having a clean air, but it kind of comes out of from below through some holes. That's why you have to actually have the mask, so you're not infecting the sterile technique. So this is what we are using, and a lot of nurses in the ICU that are dealing with COVID positive, if the institution have this, these are supposed to be the best technique to protect yourself. So with that, I think we are happy to take some questions, but a couple of the myths that I wanted to talk about is obviously pretty much everybody knows that this virus doesn't discriminate. It can infect everybody. Your presentation as a young patient would be different than older patients, because initially younger patients were under this or false sense of security that this doesn't infect the younger patients. Yes, it does. It actually, now there are reports of kids having this. But for younger patients, this is more of a complex upper respiratory infection, and the anxiety of it is worse than the actual symptoms of it. But there have been reports of patients with the ventilators in their 30s. And there's another one that affects a lot of cardiologists, is that this question of this receptor of angiotensin converting enzyme 2 as a receptor. There was this concern that a lot of our patients are using angiotensin blockers for their blood pressure and ARBs for their blood pressure, whether that would increase the receptor and potential for virus to. But the American College of Cardiology, American Heart Association both had a statement this week that yes, this is not proven, and there is no reason to stop patients from their antihypertensive. In fact, I had some patients during our call today that told me that, oh, I stopped taking my antihypertensive agent. And certainly the recommendation right now is not to.